Listen now to a discussion I had with Dr. Frank Peacock, Professor of Emergency Medicine and Emergency Medicine Associate Chair and Research Director at the Baylor College of Medicine in Houston, Texas. We cover how to use high-sensitivity troponin. Frank, welcome to ACCEL, and this is a new and very important topic nowadays with the changes in sensitivity of troponin. So give us a little bit of background on the troponins and the high sensitivity, and we can discuss some of the issues and how it relates to our practice.
Thank you for having me. I appreciate the opportunity to speak, and especially about troponins, which are, for an emergency doctor, is a really important topic. And equally important, but from the completely different side of the track, is the cardiologist's view, because we've got this historical relationship with this test where it used to be if it was positive, it was an MI, and you were done thinking, essentially. You just admitted to the CCU, and they went down the road and got cathed. That was when the assay really was pretty blind at the low level. And so the only time it was elevated was MI. Those days are completely gone. We are now to the point where we have hundreds, some have possibly as many as 250 reasons for false positives that are not MI. The trouble with it is not really false positives because the patient has an increased risk of acute mortality, and death is never a false positive. It's just not an acute myocardial infarction. And so it's requiring the way we think about this test completely different. Dispositions are different. With this has also come the opportunity in the emergency department to rule out people much quicker. It used to be, when I started, it was Q 12 hours times 3, so a day and a half later you'd rule out with your CKMB. Now we can rule out, and there were studies presented here, within an hour. So as many as 75% of the people who historically we kept and tested and hung out in the hospital or the emergency department for a day or two now can go home in an hour, or at least have a decision made about what their clinical course is going to be in an hour. It's sort of a revolution that's coming. That sensitivity is not available in the U.S. yet. The marker industry in the United States is probably 5 years behind the research effort, and that's not unusual. So the opportunity becomes one is making this transition from a non-sensitive, highly specific marker to one of high sensitivity, and the consequences, you lose specificity. So it's an educational sea change for everybody who touches this marker, which from the emergency medicine point of view is an advantage for us, better rule-outs. For the cardiology point of view, it's going to be better risk stratification, but at the consequences, we've got a lot more false positive for MI than we ever had before.
I'll mention the document called Universal Definition of MI, which sorted out type 1 and type 2 myocardial infarctions. And I think the type 1s are the ones we're looking for in the emergency room. That is the acute coronary syndrome related to an acute occlusion of a coronary artery. The type 2s were supply-demand types of troponin rises and things like that. That group still called them MIs, as you mentioned. They still relate to damage to myocytes. The question is, how do you deal with that clinically? Because in acute coronary syndrome, that's what you're looking for, is to make sure you see an acute coronary syndrome because of the associated mortality and the associated process of care. Let's take your emergency room. Are you, at this point, sending all the patients with an elevated troponin, even if you could historically get an idea, a patient in diabetic ketoacidosis or with some hypotensive type of event with an elevated troponin, are you still referring them as rule-out acute MIs to the cardiologist, or are you trying to deal with them with their underlying disorder at this point?
Yeah, so the emergency department has a different role in that we can admit to somebody or we can consult and admit to somebody else. And I think that with the knowledge that all the troponin elevations are bad, and acutely so, but if you're there with a stroke or DKA or some non-clearly type 1 MI, we tend to put those people on a medicine service appropriate for its underlying etiology. And cardiology will consult on those. And that's way different than running them off to the cath lab. You talked about the type 1, type 2. We've also screwed that up. It used to be that the MI was a 45-year-old guy who came in holding his chest. So those days are way gone. There have been large trials shown, hundreds of thousands of people, one by Canto just in the last few years, that a third of MIs are not having any chest pain. They're not silent. They had an event, they got syncopal, or they came in with epigastric pain and nausea. But the chest pain as the entree for an MI is gone. And when you read the universal definition, is they're supposed to have symptoms consistent with, and we used to think of that chest pain. By the time you're 85, chest pain is unusual. It's in a quarter of MIs. 3/4 have no chest pain. They just got nauseated or sweaty. A 90-year-old guy sweating in the ER is an abnormal thing, and we get a troponin on every one of them, or at least we're supposed to.
The clinical sensitivity of doing the troponins has to be added to the sensitivity of the test itself. So you make sure you're not missing the opportunity to measure a troponin. And I mean, somebody comes in with a sprained ankle and no other symptoms, you're not going to do a troponin. But you say an older individual coming in, it's just sweaty with no other reason, you're going to do a troponin. Yeah, so your clinical sensitivity has to be elevated as well.
And the way we deliver care in the emergency department has changed as well. It's a much more crowded environment than it was 15, 20 years ago. That has had ramifications. People think I order troponins. The reality is doctors don't order the troponins anymore because of the expedited way the EKG is done automatically by a tech who sees the patient before they're even registered in the hospital. And if we don't do that, we will never get EKGs within 10 minutes, which is a guideline-indicated parameter. Same thing happens with troponins, is that they're done by point of care commonly, they're done by nursing, by protocol, and so I inherit the patient with a sprained ankle 3 hours later who's got a positive troponin that nobody can explain, and it's certainly not an MI, but it's Bayes' theorem. The more unlikely is the disease, the more likely is a false positive, unrelated to the disease you got the test for in the first place. So we've talked about this before. You've got to understand the statistics of how this stuff works. One of the things that I think is really important is it used to be when it was positive, it was always positive. Well, we've sort of changed that. And I think of troponins more like natriuretic peptides, where everyone's very comfortable when it's low. When a natriuretic peptide is low, the probability of heart failure is very, very low. And when it's high, it's much higher. But there's a middle, it's neither low, it's neither high. And I think troponins are moving into that state as we're having troponins that look more like a bell-shaped curve than it used to be just either high or low. Now we have a situation where the troponin's very low and not moving. It's very unlikely to be in a cardiac event, and you can move on. When it's very high, there are very few things that cause a markedly elevated troponin. I mean, you can come up with some myocarditis, but MI is by far the most common reason to have a markedly elevated troponin. And so when it's very high, it's specific. But there's a big gray zone in the middle where it's neither high, you can't rule them out, it's not low, and so you have to do repeated levels and see if it's moving, which it puts them in a much higher risk group, or even if it's stable and high, which is common in heart failure and those kind of conditions, it still has prognostic value that's important. To be honest, I am very uncomfortable sending patients home with elevated troponins until I can sort it out why. The easiest example is heart failure. They come in, they always have a slightly elevated troponin. It's still slightly elevated. It's identical to the last time they were there. That person, we just give them good heart failure care, and we don't get as concerned about it. But you don't know that till you've done serial levels and had the opportunity to compare what their history looks like. And when you have a de novo presentation, you have no answer. So, I mean, that's sort of the challenge of what we've done to this marker. It used to be a one cut point only. Now it's really two, and a gray zone that's got to be sorted out.
In Europe, the troponin sensitivities are significantly higher than in the United States, and I think we're a little bit behind in getting to the high sensitivity troponin levels. Where will things go in the U.S. when we start getting these very, very sensitive levels of troponin?
In some ways, it becomes easier. As many as 75% of the people who came in with suspected ACS could have a disposition, and by that I mean they either ruled out and were so low risk they just sent them home, or they were ruled out and of some risk they thought they should do some kind of evocative stress testing or something of that nature, but they have a decision point within 1 hour. That's an advantage in the emergency medicine world, is that within an hour I'm done with my decision-making process and we can do what we need to do. Then you have the 25% that are not there, and a small percentage will rule in, and those are easy, and you're left with this group that now go in the OBS unit. And I think that's really where we're going to be in the United States, is that the majority of people rule out and leave, which is the reality of what happens now, but we do it after 18 hours of testing instead of an hour. That's tremendously valuable to the emergency department because it decrowds the place, and that's helpful. And I hope that as we get better at this and the strategies on how to handle this become standard, and they clearly aren't now. Everybody's sort of, we're in this process of, we're changing the troponin assay, so we're having educational and operational issues to catch up with it. But as this becomes firmly implanted in the United States, I think things get a lot easier in the future. So when we get the higher sensitive troponins that are common in Europe, I think everybody will have a more objective manner of handling these, because right now there's a big subjective piece where we just sort of, because our troponins weren't very good, we had to base it on risk stratification that has a lot to do with age and gender and hyperlipidemia and things that are soft predictors of acute events. And we're going to move to a very objective acute predictor. I think things get better.
Good. So I think you also emphasize the idea that there's a bell-shaped curve for the values rather than just a threshold with a yes or no answer. And I guess that's one thing we'll have to learn how to deal with, is the distribution of troponins under various circumstances of risk, age, and other things so that we can properly interpret. I gather that part of the education on troponins is still to come.
Yeah, every lab we have, with few exceptions, and troponin would be the big one, has a bell-shaped curve to it. Sodium is plus or minus a milliequivalent, and that's about it. But troponin is essentially blind. Contemporary troponins, like most people use in the United States, at least half of the measures are undetectable. So they're not really zero or something close to zero. They're just not a reading. And so in those patients, we have to figure it out, and it's not objective. As the better troponins come in, we get a truly bell-shaped curve. Each assay is a little bit different, especially with troponin I. Troponin T, there's only one antibody set, so the assay is very reproducible across institutions, but troponin I, it depends on whose company makes the assay. So we end up with different cut points, but something around the 10 or 15 picogram per mil range is going to be the 99th percentile, and below that you're normal, and above that you're not. And the sorting of the not becomes the challenge.
Okay, much more to come on the high sensitivity stage because we haven't seen the issues in the United States yet, but in Europe I think we're going to get some experience from the Europeans using the high sensitivity troponin. So we're going to have you back again to talk about the next generation of troponins sometime in the future, but I do appreciate very much you being here and talking about troponins because it's becoming a very, very important topic in the world of practice of cardiology in these days. So thanks again for being here.
Thank you. Thanks very much.